Hello students, I welcome you all to OBJY with Mackler. So in today's module, we are going to discuss about an important topic which is termed as dysmenorrhea. So what do you mean by dysmenorrhea? So dysmenorrhea, in this, dis stands for painful, as well as menorrhea means menstruation. So it is ideally the painful menstruation which is going to occur in a female. So this dysmenorrhea can actually be classified into two types. One, it is termed as primary dysmenorrhea, and second, it is classified as secondary dysmenorrhea, right? So this primary dysmenorrhea is also termed as spasmodic dysmenorrhea. It is actually the cramps and the pelvic pain the female is going to experience during the menstruation, and this spasmodic kind of pain is going to occur in a female due to the release of a prostaglandin which is known as prostaglandin PGF2 alpha. So because of the release of prostaglandin PGF2 alpha just before the menstruation, the female is going to have vasoconstriction. So because of this vasoconstriction that is going to occur, the female is going to experience cramps and pelvic pain. Now, why this PGF2 alpha is going to get released? It is because of the fact that we all know that in the second half of the menstrual cycle, the hormone which is going to be predominant is the progesterone. Am I right? Yes. So, in the second half of the menstrual cycle, the hormone which is going to be predominant is progesterone. And this progesterone is getting released by the corpus luteum. So, corpus luteum releases the progesterone, right? Yes. Corpus luteum is formed only after the ovulation is going to occur. So, corpus luteum releases the progesterone, and this progesterone is going to be maximum on day 22 of the menstrual cycle. So day 22 of the cycle, the progesterone is going to be maximum. So progesterone in higher concentration is actually going to have some negative feedback on the FSH and the LH, right? So because of the negative feedback on FSH and LH, there is going to be decreased in LH, right? So decreased in LH is going to be there because of the negative feedback. So because of the LH is going to decrease, we all know that LH is the hormone which maintains the corpus luteum in non-pregnant female. So as the LH is going to decrease, the corpus luteum is going to get degenerated. So because of the degenerated corpus luteum, there is no longer progesterone, because we all know that corpus luteum is only going to secrete the progesterone. As the corpus luteum is going to get degenerated, then the level of progesterone is actually going to get decreased. So as the level of progesterone is going to decrease, therefore the endometrial support is lost and the patient is going to menstruate. During this menstruation, as the progesterone support is lost, there is going to be release of PGF2 alpha from the endometrium. So as this PGF2 alpha is going to get released from the endometrium, it is going to initiate vasoconstriction. So because of this vasoconstriction, the patient is going to experience cramps and pelvic pain. So ideally, it is a physiological phenomenon which is going to occur in every other female, but not everyone experience this kind of spasmodic dysmenorrhea. It is variable from each female to other, right? So because of this release of PGF2 alpha, there is going to be vasoconstriction and the female is going to have spasmodic primary dysmenorrhea. So what are the ideal characteristics of this dysmenorrhea? So the ideal characteristics are that this kind of primary dysmenorrhea usually occurs either during the menstruation. So the pain will occur during the menstruation, or just 3 to 4 days before the menstruation, the patient will start experiencing such kind of pain. Okay, and as the patient is going to menstruate, in 48 to 72 hours after the menstruation, this pain is actually going to become subtle. The pain is going to get decreased in intensity. And what is the location of this pain? The pain is going to be suprapubic in location. So it is actually centralized in location in the suprapubic area. The patient is going to experience such kind of spasmodic dysmenorrhea. Now, you tell me whether the patient is going to experience the same kind of pain throughout her life, throughout her menstrual cycle? No. Why? Because is that we all know that a female is going to enter different stages of alterations throughout her life, right? She is going to get married, she is going to have coitus with her partner, and simultaneously she is going to deliver a child, giving birth to a child. So as the cycle of a female is going to get altered, this kind of pain is actually going to alter in intensity as well. So once the female is going to enter into the different stages of her life, this pain will actually become subtle, right? Yes. Okay. So what is the management of this primary or spasmodic dysmenorrhea? So since the patient is complaining me of pain during menstruation, which is actually due to the release of PGF2 alpha, I have nothing to do with any kind of pathology here, since everything is happening because physiological phenomenon. Now my only concern is only the symptomatic management. So the patient came to me with the complaints of pain. So what is my role? So my role is actually to do symptomatic management. I have to alleviate her pain. So if the pain is going to be mild to moderate in intensity or severe in intensity, if it is going to be mild to moderate in intensity, I have to give her some painkillers such as non-steroidal anti-inflammatory drugs. Just in case the pain is going to be very severe kind of pain and the patient can't even bear enough the pain, you have to make her cycles anovulatory. So what do you mean by anovulatory cycles? So anovulatory cycles are nothing but, since we know that only if the ovulation is going to occur on day 14 of her cycle, then the corpus luteum will get released. Once the corpus luteum is going to get released, the progesterone will get formed. Progesterone in higher concentration will decrease the LH. As the LH is going to decrease, the support to the corpus luteum is lost. So corpus luteum degenerates. The levels of progesterone is actually going to get decreased, and from the endometrium, PGF2 alpha is going to get released. So I have to stop all these phenomena by doing what? By stopping this ovulation which occurs on day 14 of the cycle. So in order to make the cycles anovulatory, in order to stop the ovulation, I have to give some contraception. So with the help of contraception, the patient will not experience menstruation. The cycle will actually get skipped. So the female will not experience any kind of menstruation. So this can be attained with the help of oral contraceptive pills. So I have to start the female on oral contraceptive pills in order to make her cycles anovulatory. So by making her cycles anovulatory, the patient will not experience any kind of menstruation. So since she is not experiencing any menstruation, therefore she will not experience any pain. So she will not experience any pain as well, right? Okay. So until now, whatever we have discussed is all about primary dysmenorrhea. So this primary dysmenorrhea, which is also known as spasmodic dysmenorrhea. Now let's discuss about the second one, which is termed as secondary dysmenorrhea. So what do you mean by secondary dysmenorrhea? So exactly opposite to whatever we have discussed in primary dysmenorrhea is secondary dysmenorrhea. So the secondary dysmenorrhea is also known as congestive dysmenorrhea. So primary dysmenorrhea is spasmodic dysmenorrhea. So the spasm is going to happen because of this release of PGF2 alpha from the endometrium. But the secondary dysmenorrhea is actually a congestive kind of dysmenorrhea, and this congestion is actually caused by some kind of pelvic pathologies. What are those pelvic pathologies? So what are the pathologies which will present with severe dysmenorrhea? So the most common is going to be endometriosis. So what is endometriosis? So everything about these conditions we'll be discussing in the subsequent modules, but as of now you have to learn what are these conditions which will present with dysmenorrhea. So endometriosis is nothing but, we all know that this, let's say for example, this is the uterus, okay? We all know that uterus is having a uterine cavity as well as it is going to have some muscular layer. So there are different layers of uterus such as the myometrium, perimetrium, endometrium, right? So similar to that, one layer, the uterine cavity, is termed as endometrium. So ideally this endometrium is going to be present in the uterine cavity. If this endometrial tissue is going to present in any other ectopic location instead of the uterine cavity, it is termed as endometriosis. So ectopic endometrial tissue implantation is termed as endometriosis. So ectopic endometrial tissue is termed as endometriosis. So because of this endometrial tissue getting implanted at a different location other than the uterine cavity, it is termed as endometriosis, and this condition is going to present with severe dysmenorrhea. And then adenomyosis. What is adenomyosis? As we have discussed, uterus is going to have a muscular layer as well. This muscular layer of the uterus is termed as myometrium. So what is actually going to happen is this endometrial tissue, the endometrium which is present in the uterine cavity, is actually going to grow inside the myometrium. So this endometrium is going to grow inside the myometrium. So the junctional zone is going to get altered since this endometrium is going to grow into the myometrium, right? So this condition where the endometrium grows into the myometrium is termed as adenomyosis. So this condition is also going to present to you with pain, dysmenorrhea. And then any kind of pelvic inflammatory diseases. What are pelvic inflammatory diseases? Pelvic inflammatory disease is actually an infectious condition, and this infection is going to result in inflammation of the pelvis. So this infection is actually polymicrobial in nature. What is polymicrobial? It can be caused by many agents as well. The most common agents are chlamydia, gonorrhea, genital tuberculosis as well, right? So these are the agents which are going to cause infection and inflammation of the pelvis. So since this pathology is involving the pelvis because of this adenomyosis, endometriosis, pelvic inflammatories and so on, because of these pelvic pathologies, the patient is going to have congestive kind of painful menstruation. So what are the ideal characteristics of this secondary dysmenorrhea, which is going to distinguish the secondary dysmenorrhea from the primary dysmenorrhea, is that we have seen that in primary dysmenorrhea, the pain is going to occur either during the menstruation or just few days before the menstruation. But in secondary dysmenorrhea, the pain is going to occur even more much before the menstruation, and it is going to remain even after the onset of menstruation in the female. So let's say, for example, the female is having a regular 28-day cycle, right? So much before this 28 day, the female is going to start experiencing this secondary dysmenorrhea, right? And even after menstruating, after this 28 days, the patient is going to have this pain persistent even after menstruation. Whereas in primary dysmenorrhea, we have seen that, let's say for example, in a 28-day cycle, the patient is going to experience this pain either 3 or 4 days before the menstruation, and 48 to 72 hours, this pain is going to actually decrease in intensity. Okay, that is primary or spasmodic dysmenorrhea. Whereas in secondary or the congestive dysmenorrhea, this pain is going to occur much before the menstruation. So many days before the menstruation, this pain is actually going to start in this female, and this pain is going to be a congestive kind of pain because of these pelvic pathologies. And even after the menstruation, even after the onset of menstruation in the female, this pain is going to be persistent in the female even much days after the onset of menstruation in the female. So before also, after the menstruation also, the pain is going to be persistent for many days. So by this feature, we can distinguish primary from secondary dysmenorrhea, right? We have seen that primary dysmenorrhea is actually suprapubic in location. It is actually centralized in location. We can't say that this pain is going to be localized to one quadrant of the abdomen. Since it is going to be because of release of PGF2 alpha prostaglandin, this pain is going to be centralized in location. So it is going to be diffuse in nature. Whereas in secondary dysmenorrhea, since it is occurring because of the pelvic pathology, the secondary dysmenorrhea, the patient is going to experience this pain in a localized location. So the patient is going to experience localized kind of pain. So this congestive dysmenorrhea is going to be localized to one side of her abdomen. So let's say for example, the patient is going to say that she is having suprapubic tenderness, suprapubic pain. So it is going to be localized in nature. Whereas in primary dysmenorrhea, the pain is going to be diffuse in nature, right? So the patient can also have pain in the suprapubic area, or it can be like diffuse abdominal pain which is spreading to her thighs, low backache, etc. Whereas in secondary dysmenorrhea, the pain is going to be localized to one specific quadrant, right? And this pain is not going to get settled after the onset of menstruation. To be even more particular, the intensity of the pain is actually going to get progressed. So the pain is actually get progressed even after the menstruation. So even after the onset of menstruation, the intensity of the pain is even going to get increased even more. So what are you going to treat? What are you going to manage the patient? how are you going to manage the patient? So, as in primary dysmenorrhea, we treat it only symptomatically with NSAIDs, and severe kind of pain, we make the cycle and ovulatory with the help of oral contraceptive pills. But in secondary dysmenorrhea, since we know this is occurring because of the pelvic pathology, we can't just give NSAIDs to this patient, right? You can't give NSAIDs and reassure the patient, and you can't ask the patient to leave, because this kind of condition is happening because of some pelvic pathology. So what are you supposed to do is you have to order an ultrasound, right? You have to order an ultrasound. So in the ultrasound, you have to check for any pathologies, if there is endometriosis, if there is adenomyosis, etc. Right? Endometriosis, adenomyosis, features of pelvic inflammatory disease, or any other pathologies, any other pelvic pathologies being present or not. If at all those pathologies is going to be present, now you have to treat these pathologies. So only if you're going to treat the pathology, the patient is going to get relief from this congestive dysmenorrhea. Right? For time's sake, you can give NSAIDs and ask the patient to leave, but definitely you have to ask the patient to come to you again with the ultrasound report being done, ultrasound abdomen and pelvis, and check for any of pelvic pathologies being present. And if at all it is going to be present, you have to treat the disease either by medical management or surgical management. If at all required, you have to treat the female, right? So only when you are going to treat the pathology which is existing in the female is actually going to experience relief from this congestive or secondary dysmenorrhea. So whatever we have discussed until now is all about dysmenorrhea, that is painful menstruation. So let's meet in another important, beautiful session with another interesting topic. Until then, please keep studying, students. If you have any reviews to be written to us, please answer, or please you can